The following podcast is part of a certified educational activity titled AD Safe, an initiative to build understanding of ARIA and skills needed to improve detection and optimize response in specialty care. Access the entire activity and complete the post-test at peerview.com/YCM860. Downloadable slides and practice aids are also available.
Hello, and welcome to AD Safe, an initiative to build understanding of ARIA and skills needed to guide treatment decisions and support rapid recognition and response in specialty care. I'm Stephen Salloway from Brown University, and I'm joined today by Eric Musiak from Washington University.
Hi, Steve.
Hi, Eric. Glad you could be here. There are a number of objectives for today's program. We hope you'll deepen your understanding of the mechanisms driving ARIA and patients receiving amyloid-targeting therapies, sharpen your ability to recognize clinical signs and symptoms of ARIA, refine your approach to ARIA detection and diagnosis, strengthen your skills in monitoring and managing ARIA, optimize collaboration across AD care teams, and enhance your techniques for patient and care partner discussions, which are essential for shared decision-making. Now, it's really critical to select patients that are most likely to benefit from treatment and also have a favorable risk profile. And this involves really a shared decision-making process with the patient and the family. So as you know, there are two drugs approved that lower amyloid plaques in the brain. They're designed and approved for people with early Alzheimer's disease, either mild cognitive impairment or mild dementia. They have confirmed amyloid pathology. There's an MMSE range, depending on the drug, from 20 to 30. APOE genotyping is required to evaluate the risk profile of the patient. And the patient must have a baseline MRI that's carefully reviewed for safety. Now, it's also important to know about exclusions. People have to be able to undergo safety MRIs during the treatment period. We look for signs of CAA, no more than 4 microhemorrhages, any area of superficial siderosis, severe subcortical hyperintensities, any area of macrohemorrhage or really prior episodes of macrohemorrhage. Anticoagulant use currently is a relative contraindication. They have to be stable medically. They cannot have other immunologic disorders that may put them at higher risk of a severe inflammatory response. And then, depending on where you are in the world or in what healthcare system you're in or your own treatment protocol, you may be restricted or may make your own limitations on treating patients who are homozygous for APOE4. They're at highest risk of having ARIA and more serious ARIA.
So let's talk about our first topic here, which is it ARIA? A treating clinician's guide to accurate detection and monitoring. So ARIA, or amyloid-related imaging abnormality, is one of the main side effects of these anti-amyloid therapies that we're going to talk about in this session. And it is a class effect. So it happens with all monoclonal antibodies that target amyloid beta. And we think it's the result of antibodies binding to accumulated amyloid beta within the primarily the cerebral vasculature, so cerebral amyloid angiopathy. When these antibodies bind to this cerebral amyloid accumulation, it can cause an inflammatory response that leads to loss of integrity of the vessel wall, leakage of fluid, and edema around the blood vessels, which is ARIA-E or ARIA-edema. It can also cause microhemorrhages and heme products to accumulate around the blood vessel, which is ARIA-H or ARIA-hemorrhage. So the antibody-mediated inflammation and blood barrier breakdown, which causes edema, is ARIA-E. It's analogous to amyloid beta-related angiitis, which you can see in patients spontaneously who have cerebral amyloid angiopathy. And then this mobilization of parenchymal A beta from plaques, we think it leads to a transient overload of perivascular drainage systems and vascular heme deposition. So you get heme around the blood vessels. That's what forms these microhemorrhages, which is analogous to typical findings of CAA. So let's take a closer look now at how this process unfolds at the molecular level.
Alzheimer's disease and cerebral amyloid angiopathy are both caused by the accumulation of amyloid beta aggregates, which are deposited into the brain parenchyma in AD and into cerebral blood vessel walls in cerebral amyloid angiopathy. When amyloid-targeting therapy is initiated, antibody-mediated breakdown of amyloid plaque and mobilization of parenchymal and vascular amyloid beta leads to loss of vessel wall integrity and blood-brain barrier breakdown. As a result, proteinaceous fluid and/or red blood cells can leak into the parenchyma or the leptomeningeal space, which may result in edema, also known as ARIA-E, or microhemorrhages and superficial siderosis, also known as ARIA-H. ARIA typically occurs within the first 6 months of treatment and is detected through MRI imaging. Some evidence suggests that cerebral blood vessel wall integrity improves with continued use of amyloid-targeting therapies. Therefore, the risk of ARIA usually decreases over the course of treatment.
So now that we've seen how the molecular pathogenesis of ARIA unfolds, let's talk a bit more about the clinical ramifications. So one of the major risk factors for ARIA that has been identified in both lecanemab and donanemab trials is the ApoE epsilon 4 allele. So ApoE4 is a major risk factor for Alzheimer's disease and CAA, but it is also a driving force in ARIA risk. And so this slide shows data from both the Clarity AD study looking at lecanemab and the TRAILBLAZER-ALZ 2 study looking at donanemab. You can see in both cases, if you look at ARIA-E, for instance, in the lecanemab data, about 5.4% of non-ApoE4 carriers had ARIA, whereas 32%, 32.6% of ApoE4 homozygotes had ARIA-E. And we see the same pattern for ARIA-H in the lecanemab data as it goes from 11.5% in the non-carriers all the way up to 38.3% in patients who have ApoE4 homozygosity. The data is similar in the donanemab trial. The numbers are a little bit higher. ApoE4 non-carriers showed about 15% developing ARIA-E, whereas up to 40.6% in the ApoE4 homozygote group. The numbers for ARIA-H are even higher. 18.8% of non-carriers develop ARIA-H, whereas 50.3% of ApoE4 homozygotes develop ARIA-H. Now, I think it's important when you're comparing these two studies to understand that the patient populations were not exactly the same. The donanemab trial used tau PET to stratify their patients and thus may have had patients that had slightly more pathology when they were treated. But this is still high numbers. So there's been some advance in this. So a recent study called TRAILBLAZER-ALZ 6 tried a modified titration schedule for donanemab to try to lower this ARIA rate. You can see here in the picture that modified titration is very simple. It's essentially just moving one dose of the drug from the first dose to the third dose. So it's really a very minimal change. But as you can see on the right-hand side, comparing the orange bars to the blue bars, the modified titration, which is the blue bar, lowers the rate of ARIA in all of the different groups. And this is looking at ApoE4, homozygotes, heterozygotes, and non-carriers. But you can see the ApoE4 homozygote group, the modified titration has a really striking effect, lowering ARIA-E rates from 57% all the way down to 19%. So we're very optimistic that this new titration schedule can help lower this risk of ARIA-E for donanemab, particularly in E4 homozygotes. Now, this new titration schedule has already been approved for use in Australia, and there's new regulatory labels expected. There are several updated appropriate use recommendations which incorporate this new titration schedule. It's not yet approved in the United States, but it is already been adopted by many Alzheimer's disease treatment clinics worldwide, including the one that I work at. So we're hoping this new titration schedule can lower rates of ARIA and potentially open the door to further changes in the titration schedule in the future that could lower it even further. So what are the risk factors for ARIA? So as I mentioned, APOE4 carriership, homozygotes are at very high risk, but heterozygotes have a slightly higher risk of ARIA. The stage and point in the treatment schedule. So the majority of ARIA events happen in the first 6 months of treatment, and most severe cases are in the first 3 months. So you have to keep a very close eye during the beginning when you first initiated treatment for ARIAs. That's when it generally happens. Baseline markers of cerebral amyloid angiopathy, CAA. So we count the number of microhemorrhages on the MRI, and we'll get into this a little bit more later. If there's too many microhemorrhages at baseline, a patient may be at high risk for ARIA or ineligible. The extent of ischemic white matter changes. So if you have a lot of white matter injury, you have a higher risk. Sometimes this can indicate CAA. And use of anticoagulant therapy. So, there's always concern that there could be a macrohemorrhage, and certainly that risk is higher in patients who are anticoagulated. So let's talk a bit about the classification of ARIA-E and ARIA-H. So ARIA-E is classified by MRI features. These are imaging abnormalities, and so it's primarily a flare abnormality on the flare sequences. You can see in the picture there's parenchymal edema. In this case, there's left parieto-occipital lobe parenchymal edema and effusion. So there can be leptomeningeal or sulcal effusion of fluid that can be seen primarily on the T2 flare sequences. And ARIA-H is indicated by microhemorrhages, which are seen usually on the GRE or T2 star images, or even more effectively using SWI or susceptibility weighted imaging sequences. So you're looking for multiple punctate foci on the SWI image indicating microhemorrhages. Another indication of ARIA-H is superficial siderosis, which is leptomeningeal hemosiderin deposits, usually around the edges of the brain and the sulci, again seen on T2 star GRE or SWI images. And so there's grading scales for ARIA. In general, I have to say that most of the ARIA is mild. We see pictures of very severe ARIA just to illustrate it, but in clinical practice, by far most of the ARIA that we see is mild and can be very subtle. And in fact, having radiological colleagues that can identify very subtle ARIA is important. But in general, if you look at ARIA-E, if you have a single hyperintensity in one location that's less than 5 centimeters, it's mild. If it's more than 5 to 10, then it's moderate. If it's greater than 10 or in multiple sites, then it's considered severe. ARIA-H with microhemorrhages, 1 to 4 new microhemorrhages is considered mild ARIA-E. 5 to 9 is considered moderate, and more than 10 is severe. Superficial siderosis ARIA-H, 1 focal area of superficial siderosis is mild, whereas 2 is moderate, and more than 2 is severe. So you can understand how it's very important to have a very good baseline MRI, because if you miss microhemorrhages on the baseline MRI, then it may appear that you have new microhemorrhages on subsequent MRIs, and this can influence whether or not you stop treatment. So let's talk a bit about the MRI protocol guidelines. So having quality MRIs is really important, and consistent MRIs. If it's possible to keep people on the same scanner throughout, that's always the best. 3T scanner is recommended, just higher resolution. The 1.5 T scanner is acceptable. It's considered the minimum standard. Below that is really not recommended. You want thin slices. Some of these are very specific things that the radiologists probably have to deal with, or the technicians at the center. But in general, it's important to get either GRE or SWI, or ideally both. If you have a patient that you're monitoring for ARIA and you don't get those sequences, any of these iron susceptibility sequences, it's not going to help you very much. You also want to have T2 flare. It's pretty standard in MRIs, but to have an SWI and T2 flare is really critical to monitor for ARIA-E and ARIA-H. It's also important to have diffusion-weighted imaging to make sure that there hasn't been an acute stroke. So there's a few things to kind of consider when you get the baseline scan. So the baseline scan needs to be done within a year of the onset of treatment initiation, and preferably as close to the beginning of treatment initiation as possible. Being consistent about the imaging is really important, and getting a high quality first image. This is really critical because later in the course, on the third or the fourth MRI, if you start to see new findings and you didn't see them on the first image, you need to be certain that they're actually new and that they weren't just missed because the first image was a low quality image. So it's important. I think we consistently use 3T at our center if we have that availability. And your report, it's important that the radiologists that you work with are able to produce a report that actually counts the number of microhemorrhages and indicates whether or not they're GRE or SWI, because the numbers will be different, so that you can track those over time. Also mentions if there's any regions of superficial siderosis, uses the Physicus scale to tell about the degree of white matter hyperintensity burden, mentions any chronic infarcts or any other kind of lesions that might exclude you from treatment, like aneurysms or AVMs. So ARIA monitoring. So there's schedules that are on the labels for these different drugs are slightly different for lecanemab or donanemab. But I think, first of all, it's important to make sure that you can find MRI facilities that are relatively convenient for the patients and that provide quality scans and have consistency in terms of their imaging protocols, that they have the scans that we just mentioned, and that they can provide you with a report that gives you the key pieces of information in a timely manner. I think timing of this and the logistics are very important because you want to get these MRIs before the next infusion happens. And that can take, not only does the MRI need to be done, but it needs to be reviewed to make sure there isn't ARIA before the next infusion starts. And in the case of lecanemab, these are fairly short windows. We only have 2 weeks. So for lecanemab, you have this initial baseline scan, which is done within 1 year of the starting the drug. And then you have another MRI after the 5th and 7th infusion and the 14th infusion. And then sometimes MRI needs to be added. If patients develop ARIA, you may want to add more to make sure that that's resolved if you hold treatment. For donanemab, again, there's a baseline MRI within 1 year. There's actually one extra MRI that's required with donanemab. There's after the 2nd infusion, after the 3rd infusion, and the 4th infusion. I think this indicates that with donanemab, ARIA happens really early. If you can make it through the 4th infusion, then you go all the way to the 7th, and after that, the ARIA rates are quite low, and you don't need standard scheduled MRIs unless something happens. So what are the symptoms and signs of symptomatic ARIA? When should we be getting this MRI? If you get a call in the night that your patient who's on lecanemab is suddenly having some symptom, how do you know if you need to rush them to get an MRI? And it can be very difficult because these are somewhat vague, and there's a large number of neurologic symptoms that these patients can have. They can have headache, confusion, and altered mental status, or kind of delirium-like symptoms is a very common one. Dizziness, vertigo, ataxia, also common. Some patients have nausea or vomiting. Some just have kind of nonspecific fatigue, blurred vision, vision impairment, disturbance, gait disturbance, seizures. Obviously, some of these you're going to immediately probably move to get them an MRI. Certainly, if a patient has a seizure or if they suddenly have stroke-like symptoms, stroke is always on the differential for patients that are on these drugs, and so some judgment is required. Certainly, the severity can influence whether or not you're going to get an MRI. Milder symptoms, obviously, things like a mild fatigue is probably not something you rush them off to get an MRI for, but If you have moderate symptoms that really impact daily living or severe incapacitating symptoms, then you probably need to get that MRI more quickly. And, detecting ARIA is challenging, and radiologists need to be trained in this, but there are some tools that are coming along, including this thing called IcoBrain ARIA, which is now FDA cleared, which is a automated software that can detect ARIA and give you ARIA grading information. So this type of software will probably become more prevalent as these drugs are disseminated throughout the community to sort of help take some of the guesswork out of detecting ARIA.
Okay, thanks, Eric. That was a great overview. Let's talk about best practices for managing ARIA in the specialty clinic. So ARIA is, as you've heard from Eric, is commonly asymptomatic and usually found on the safety MRI scans. You've heard about the symptoms that can occur. And Eric is right that it takes some clinical judgment because some of the symptoms are vague or mild, and you're not sure if they're related to treatment or not. We usually err on the side of being a little more conservative to make sure we're excluding ARIA, but often, again, it requires clinical judgment. For more serious cases, you need a plan in place. These don't occur very often, but they can occur. I just had a colleague of mine call me yesterday with one of severe symptomatic ARIA. So you need a plan for emergency care and for hospital care. And that usually involves, if it is severe inflammatory ARIA, empiric use of IV methylprednisolone with a taper of the corticosteroids. A key issue is really the stroke mimic. ARIA can present, again, not very often, but occasionally, with focal signs and symptoms that mimic a stroke. And so you need a plan in place to make sure that the patient gets the appropriate treatment in that circumstance. Things that can help are having a patient ID card or identification bracelet that they can carry with them, or the family member can carry with them in case they have to go to the emergency room. They can let the treating physicians there know that they're on an amyloid-lowering drug. Having alerts in the medical record, electronic health record, is really helpful so that treating clinicians know that they're on an amyloid-lowering treatment and that there could be contraindications, for example, for use of thrombolytics. Now, it's important. This is an algorithm that was really adapted from the phase 3 trials that's in the appropriate use recommendations. It's also in the FDA label, though not required. It's a guidance in the FDA label. But we recommend that you follow this, this algorithm for managing ARIA. So if the patient is asymptomatic and the ARIA-E is radiographically mild, there's the option of continuing treatment with clinical and MRI monitoring and to make sure that it resolves, that it's going in the right direction. You also may choose to be more conservative and wait for the ARIA-E to resolve and then resume treatment. If it's symptomatic or radiographically moderate to severe, then the plan should be to suspend treatment, monitor clinically and with MRI until the ARIA-E resolves and the ARIA-H stabilizes. The microhemorrhages won't go away typically, but you want to make sure they're not still accumulating. And then once it does resolve and stabilize, you can decide whether or not to continue to resume treatment. So the informed consent and the risk-benefit profile is really ongoing discussion with the patient and the family, depending on the circumstances and the evolution of their clinical course. Now, there's guidance about when to stop treatment. If the patient has a macrohemorrhage, certainly for multiple areas of superficial siderosis, for more than 10 microhemorrhages, you have to be very careful in patients with more than 2 episodes of ARIA, severe symptoms of ARIA, patients who now require anticoagulant treatment. These should be all cautionary in terms of discontinuation. Let's say a patient survives a severe episode of ARIA-E, that's good, and they have a good outcome. We don't want to re-expose them and then risk the likelihood of a more serious outcome the next time. There have been cases, unfortunately, of patients who had a ARIA presented as a stroke mimic. They went to the emergency room and they received thrombolytic treatment, and a number of them, unfortunately, had severe hemorrhage and were fatal. We want to avoid those cases. So, number one, if it is a stroke, which again, anything can happen in medicine. So they can have ARIA and a stroke, or they can have a stroke actually that looks like ARIA. So you have to determine that getting an urgent MRI is really helpful to differentiate between ARIA and stroke. But if it is a stroke, again, you'd want to avoid thrombolytics if possible. It may not be possible. You'll have to weigh the risks and the benefits. But consider, if there is a large vessel occlusion that's accessible, mechanical thrombectomy to treat the ischemic event rather than relying on thrombolytic treatment. Now, if patients go on anticoagulation, again, the conservative recommendation at this point is to then suspend the treatment with the amyloid-lowering drug and see if the patient can get off the anticoagulation. But while they're on it, we wouldn't be giving both together typically. Collaborating with a multidisciplinary team to optimize ARIA detection and management. So it's very helpful, and some clinicians are on their own, and so you have to build whatever support you can locally. Certainly you need infusion center, you need good radiology support, teamwork. Others, Eric comes from a very large center. We have a very active team approach here with multidisciplinary care, which is really helpful. We have an ongoing case conference where we review all the cases to determine eligibility, and then we also monitor. We review all the MRIs, and we monitor for safety and also help with management of ARIA. So it really helps to have that framework if that's available to you. It's also helpful to have a protocol, to be very specific, and we sort of laid out for you based on the label and the appropriate use recommendations, who qualifies and who should be excluded. And you want to have that in writing. We also, at our center, obtain written informed consent, where we describe to the patient what their risk is based on their own comorbidities and APOE genotype, and tell them what can occur, and that they then, if they are an appropriate candidate and want to proceed, that they accept that risk. So it's good to have that in writing, and you may need to renew that if they develop more serious ARIA along the way and want to resume. Again, that's an ongoing discussion. Okay, and then Eric mentioned to you about working carefully with radiology. That's really important. So you want to have a radiology team that's prepared for this. Good quality MRI, good quality reads, standardized reads. Over time, I think we'll see more automated software coming into clinical practice, so that will assist both the radiologist and the clinician with the reading. And ideally, your radiologist should be notifying you, especially for any serious cases of ARIA. They should be getting you on the phone right away so you can react in real time to that new information and help manage the care. Okay, what should the emergency team know? So in case the patient does need to go to the hospital, it's helpful for them to know that the patient is on an amyloid-lowering drug, that ARIA, if there are focal signs, ARIA can present as a stroke, so they need to have that in the differential. If they know the APOE status and how long they've been on treatment or any prior episodes of ARIA, that's helpful. That may or may not be available. ARIA can produce bad, serious inflammatory ARIA can cause seizures, so they need to know about that. And then thrombolytics, especially if it's ARIA and not ischemia and not an ischemic event, thrombolytics should be avoided because then there could be a really severe outcome there. So that's very important, either in the electronic medical record. Increasingly, this will become a common knowledge in clinical practice, but we're in that transition phase right now as emergency and stroke doctors are getting more familiar with this. Getting an urgent MRI is helpful because you can differentiate ARIA from stroke there, especially if you have a diffusion weighted image. CT is not sufficient for detecting ARIA. It's not sensitive enough. And then if it is ARIA is the primary cause of this symptomatic event, then high-dose corticosteroids and monitoring and treating seizures if they're present is important. Okay, weighing risks and benefits. So this is the cornerstone of good medical practice. We make the diagnosis. We talk about whether or not they're a candidate for an amyloid-lowering treatment. We go over the expected benefits. It can slow down the disease process. People can remain in a milder state of Alzheimer's longer with better quality of life. Those are things patients want. It can cause ARIA. That's the biggest risk. And ARIA, as Eric said, usually is mild and asymptomatic, but it can be serious, especially if they're an E4 homozygote or they have CAA plus CAA on their baseline MRI. That puts them at risk of having an event and a more serious event. So they need to know what that risk is. Now, as I said earlier, in some countries or some healthcare systems, E4 homozygotes are restricted. They're not permitted to be treated. The FDA label is open about that. There's a black box warning in there that there can be a fatal outcome, cerebral hemorrhage, severe edema in those patients who are E4 homozygotes. But again, we have the option, again, if your treatment center, if your protocol allows it, to weigh the risks and benefits with those patients, again, being conservative with them, but giving them the opportunity, if they are good candidates, to be treated. Obviously, we always have to weigh in the cost of care, insurance coverage, and so forth, and that's still evolving. And there may be co-pays, and so patients need to weigh that out and look for support for that. And then there are other treatments available, and we need to weigh those, and also research. Many of these patients are eligible for research trials, and they may want to choose, and they may choose that. Increasingly, some research trials are allowing treatment with amyloid-lowering therapy as a background treatment, so they can do both. There's some practical issues with treatment. Currently, lecanemab is every 2 weeks IV. There is a sub-Q formulation that could be approved in the future. Donanemab is monthly IV. That's attractive for many patients because they have to come less often. Donanemab also has a stopping rule, which a clinician could decide to use and get a follow-up amyloid PET scan. And if they're now negative, which the majority will be negative, then at 12 or 18 months, a discussion could be had with the patient whether or not to continue treatment. And so some people find that attractive. Okay, now we'll watch a short video demonstrating a clinician educating a patient, our colleague, Sharon Cohen from Toronto, about the risks and benefits of treatment with ATTs so that she can make an informed decision about whether or not to initiate treatment.
Hi, Connie. It's good to see you again. When we did cognitive testing, we saw that there was mild difficulty with memory, but overall your scores showed what we would call mild cognitive impairment, not in the dementia range. So I had mentioned that there are some new treatments and that we should have a session where we talk about those. So would that be okay then if we go ahead and talk about
Yes.
these treatments?
Yes, I'm really interested in hearing about options.
Super. I love that you want to be proactive and because we've caught your condition early, that gives us the opportunity to intervene early rather than wait till things get gradually worse and then try and play catch up. The two new medicines that we have are both antibodies given by intravenous infusion, and they slow down the progression of Alzheimer's disease. So people stay mild longer and are at lower risk of progressing to a more disabling stage of disease. We feel as a scientific community this is worthwhile, but what about you? What would your goals be?
Well, I think I told you my mother died at 78 of Alzheimer's, and so I kind of know what the future looks like, and I'm willing to try anything that will delay that progression.
So the antibodies we have, they can have some side effects. Fortunately, for the most part, these side effects are mild, they're manageable, and I want to tell you a little bit about them. The most important side effect is something called ARIA, amyloid-related imaging abnormality. And why imaging? Well, that's on an MRI scan. We can see on the MRI scan sometimes early in treatment little spots of blood or swelling of the brain. And most of the time, this happens without any symptoms. If we didn't do the MRI, we wouldn't know it's happening. Most of the time, this ARIA event resolves spontaneously without any intervention. However, rarely there can be symptoms, and even more rarely, the symptoms can be serious. So that's why I want to make sure you're aware. When symptoms do occur, they can be in the form of headache, and it might be a very nondescript kind of headache. So it might be hard to tell, is this just a usual headache or is this something more? It could be dizziness. It could be difficulty with speech or balance, walking. So it can take a variety of forms. And with an MRI scan, we can clarify, is ARIA happening? And if so, we would hold the dose of the medicine, or depending on the radiologic picture, we might stop the treatment. So what I understand from the history and the testing we've done so far is you have one copy of the ApoE4 gene. So you are at a little bit higher risk of ARIA than people who have no E4, but substantially lower risk than people with two copies. People with two copies of ApoE4 are at the highest risk. So fortunately, you're not in that high risk group for ARIA. You also had a normal MRI scan without, well, normal in the sense that it didn't show any telltale signs of putting you at higher risk for ARIA. So no microbleeds there or signs of bleeding whatsoever. That's good. Yes, and you're not on blood thinners or other kinds of drugs that could promote bleeding independently, so that is also helpful. So how do you feel? Does this put you off, or do you feel that going ahead still makes sense?
Well, I think going ahead makes sense just because I'm really interested in stopping the progression. I'm a little nervous about the side effects that you explained, and it sounds like kind of a big commitment to have the infusions and the MRIs, but I think in the long run, I hope it would be worth it for me.
Yeah, okay. No, I appreciate you considering all the factors. That's great. Why don't we get started if you and is it your husband who may be accompanying you on this journey if he feels likewise that we
Yes,
could go
he
ahead?
will be there. Yes.
Terrific.
Okay, so that was a helpful video from Dr. Cohen and the patient. And that was a pretty straightforward case of a woman who had MCI and not especially high risk based on her MRI, a little bit elevated risk because she is a heterozygote for ApoE4, but has a family history of Alzheimer's, so is very, very aware of it, which is very common that we see in practice, and is motivated to try to delay the disabling features of the illness, which is really the primary motivator for most patients. One point I'm making, I asked Eric to comment, is we typically see patients with their family because this is something that really needs to be done together with a care partner. So to monitor for symptoms, because if the patient has symptoms, they may not be capable of reporting them at the time. And also some patients are more cognitively impaired than this patient. And so weighing out the risks and the benefits, they may not be fully capable of that, or they certainly can give their preferences. So it's very important to have the family involved. I don't know if that's something you do, Eric, as well.
Yeah, absolutely. So we always have family involved, so they can help with the decision making. And also, they're probably going to be involved in the logistics of getting the patients to these infusions, to the MRIs, which it can be an issue. We have patients that come from far away, and I'm sure you do too, that, them getting to an infusion every 2 weeks or every month is going to, put a strain on their lifestyle, and they need to understand those things. I think Dr. Cohen did a great job of laying out sort of realistic expectations, both for the benefits and the risks. I think some patients are really focused on the benefit. They think they're going to be cured, and they need to understand what's realistic, and also some patients hear bleeding and swelling in the brain, and they think of really catastrophic situations. So I think they need to have an understanding that most ARIA is manageable and mild, but there is always this risk of more severe. It's rare, but it does happen. So I think she did a nice job of laying all that out. And as I mentioned, some patients are okay with all the medical aspects of it, and they're really concerned about the logistics, how it's going to impact their life, their ability to go to Florida for the winter, that kind of thing. And so I think she did a nice job of letting the patient kind of express what her concerns were so that she could address them, and that's important.
And you can imagine, Eric, that the scenario, keeps changing. So someone may be an E4 homozygote, someone may have 3 microhemorrhages on their MRI, whatever, moderate to severe white matter changes, so that this is a pretty straightforward discussion, but there's sort of every permutation of eligibility. And our experience, actually, the main reason that we decline requests for treatment is that the patient's too advanced clinically. They are more moderate. They're really not early AD, and they're very motivated, just like this patient, but there's no evidence of real benefit. So the risk benefit profile there is really not in their favor.
Yeah, that's a difficult conversation every time. We have a lot of those patients too, but I think it's important to understand, I often say to them, this risk benefit ratio, as you have more severe disease, the benefit kind of goes away, but the risk stays or maybe gets worse. So,
Exactly.
But yeah, of course, some people are very motivated. Other people are really fantastic. So, I mean, obviously, it's a shared decision making. So if you think a patient's a great candidate, I will sometimes tell them that, you're a perfect candidate.
So I think our job as, dementia experts is to determine if they're an appropriate candidate for this treatment, and then advise them, like you just said. And then it's up to them if they are a good candidate, to decide if it's right for them, and we can help them weigh that out. Okay, so we have a case for a discussion, and again, you can see that there's no right or wrong about some of these things, and there's a lot of different opinions as our practice is evolving, and also given the regulatory environment that the clinician is practicing in. So this is a 56-year-old woman who has mild early onset dementia. You can see her age. Her mean mental is 22, so putting her really in the mild dementia range. She has a positive amyloid PET scan. Her APOE is 4.4. There's a E44. There's a strong family history of AD, and she had no baseline MRI exclusions. So the question is this patient appropriate for treatment?
Yeah, well, I think it's a very hard question. Depends. As you mentioned, in some places, some countries, some healthcare systems, APOE4 homozygotes are excluded across the board. So if you're in one of those places, then I guess the answer is no. If this patient came to our center, the answer would be yes, with some stipulations that they're a high-risk patient potentially. So we could this person does, if you don't exclude them because of their APOE4 homozygosity, then, they do meet the criteria. So, it's sort of it's a trick question, I would say.
Well, I think weighing it out, if you exclude E4 homozygotes, you're going to have way less ARIA.
Yeah, that's true.
You will. There'll be way less ARIA, and there'll be less severe events. But then those patients who are at greatest risk of Alzheimer's disease, who come in fairly substantial numbers, way beyond their base rate in the U.S. population, because of the family history, are very eager for treatment. And so you have patient autonomy and they need treatment because it is a progressive and a more often a more accelerated form of Alzheimer's, especially this younger onset. So it's a tough call. I know some colleagues who are very, very excellent clinicians don't feel comfortable treating E4 homozygotes, even if they have the regulatory approval. And we're sort of like your center. We're open to treatment, but we weigh risks and benefits carefully, and we also monitor a patient like this carefully if they do get into trouble.
Yeah, for sure.
And so she went on. She decided to receive treatment, and she developed an episode of ARIA-E, and you can see that on the flare image there. And she, the ARIA-E resolved after 60 days. In this case, there was no evidence of microhemorrhage, which can co-occur with the ARIA-E or after the ARIA-E, which would make us more concerned about having, a more serious outcome the next time. So then the question is, what do you do next? So now you have this E4 homozygote, younger onset, and she's had a moderate case of ARIA-E, which she did well, asymptomatic, and that has resolved. There's no other hemorrhagic change. How would you approach this case now?
Yeah, this is a very tough case. I think that most clinicians would probably suspend treatment indefinitely with this patient. I think that many people understandably have a low threshold for discontinuing treatment in patients who are E4 homozygotes if they get ARIA. I mean, technically, if the patient was really motivated and you just accepted the fact that this was going to be a high-risk treatment, then you could keep going. And I guess it would depend a lot. To me, the most kind of important factor for that is that the patient's 56, so they're very young. They have a lot of years, and it would be great if you could slow this down for them. But they are certainly very high risk, and they would have to really understand that, in my opinion, to kind of continue.
Right. So I totally agree with what you said. So I think there'd be a wide variety of responses on the provider side about this, and also on the patient side too, depending on their risk tolerance. But I think the next step is to go back to the patient and the family, review the status now that they had the episode of ARIA, that they're increased risk of certainly having another episode of ARIA. They likely had CAA that we're not detecting, and then see what they say and then weigh that risk with them. But I would definitely, if they decide to proceed and the clinician decides to, I would definitely document that in the record, that the risk was clearly described to them and the patient and the family accepted that risk, because there could be a liability here. Now, again, you think of the permutations. If they now had 3 or 4 microhemorrhages, I'd be really concerned about resuming treatment. If they had siderosis, I'd be super concerned. So I think whatever the takeaway is, to be super careful. Whatever you decide, there's no right or wrong here. This is a lot of clinical judgment and patient preference, clinician preference, but be super careful in this case because they are at risk of a more serious event.
Yeah, and it's always a changing environment, as you said. Now, maybe this person comes back after a year and now their MMSE is 16, or something like that, and you'd probably, take that.
That makes it easier.
Yeah, that would make it
that
easy.
makes it easy. And some regulatory, again, these same regulatory environments, like in England, if you go below mild early AD, you're excluded at any point. So the regulators make it easy for the clinician. But that would make it easier. Now, there may be treatments like trontinemab, which so far, we don't know the clinical results, show very low ARIA rates in E4, including E4 homozygotes. So there may be future treatment options for someone like that. We definitely need treatment for people who are E4 homozygotes, our highest risk population in the sporadic AD category. So,
yeah,
anyway,
and I hope things like the modified titration schedule, or if we have even, further modification of that or some other, data on how to manage these patients. Because exactly, these are the people that need it the most.
Absolutely. And they're highly motivated.
Mm-hmm.
But I tell you, another key takeaway is asking these type of, every patient, but especially the higher risk patient, to let us know right away if something isn't right. And it could be something really minor, but not typical for them. so that we can evaluate and try to catch it early before something becomes more serious. So an extensive discussion was held with the patient and the family, and she decided to go back on treatment and was able to do it successfully without recurrence. So there was a good outcome here, but I can guarantee you there's not always a good outcome for a patient like this because of the risk profile so high.
So I think the key takeaways from this discussion are that safety monitoring and appropriate management is critical to the success and utilization of these new therapies, including selecting the appropriate patients as probably the most important thing. Heeding the warning signs, so being able to identify patients either on imaging or symptomatic that have ARIA and knowing how to manage that. And this involves close work and coordination with the radiology team, as well as with people in the emergency room if these patients happen to present with stroke-like symptoms. Thank you all for listening today, and thanks to Dr. Salloway for a great conversation.
Thanks, Eric, and thanks everyone for joining in today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/YCM860.